When is the last time you had a patient who was young, let's say in their 30s, with chest pain and ECG changes, and you wondered whether or not those ECG changes were real or not? Well, take a look at this week's case and see how this patient turned out. Okay, so here's the case. This was a 39-year-old male with a history of alcohol abuse who was complaining of squeezing epigastric pain and central chest pain that radiated to both arms. He vomited about 3 times and was drenched in sweat, and that's what made him nervous. Now, he had a similar episode about 6 months prior and underwent cardiac catheterization that showed only mild disease, and therefore no stents were placed at that time. Now, he came to the ED because he was concerned about this pain, and in looking at his history, try to identify some red flags. And in my mind, if you look at this, there are about 3 major problems with this history. Radiation. We know that radiation of chest pain to the arms is bad, but radiation to both arms is really bad. Keep that in mind. The fact that he was drenched in sweat, that is always, I think, a really worrisome finding in the context of someone with ischemic chest pain. And lastly, a 39-year-old male with, mild disease and cath. I'm not sure about that. Why would he have any disease? So these were the 3 huge red flags when I heard about this case. Here's the 12-lead ECG. Now, to get the most out of this case, go ahead and put this video on pause right now and see if you can interpret this ECG. One of the keys in interpreting this ECG is to really understand the QRS complex. Now, the normal QRS complex ranges somewhere between 40 to 100 milliseconds, about 1 box to 2.5 small boxes. And anything more than 100 milliseconds is really not quite normal, and anything more than 120 milliseconds really should be considered to be a bundle branch block, right? So remember that the AHA and ACCF diagnose and actually define ST elevations only in the setting of a ECG that does not show left bundle branch block pattern, or LVH. So that's an important thing to keep in mind. So let's take a look at the QRS complex. Here it is. This is V-Fib blown up for you. And the QRS width is about 100 milliseconds, about 2.5 boxes, about the upper limit of normal. And that, in fact, is okay. So one can, in fact, reliably diagnose and rely on elevations of the ST segments in an ECG like this. There's a J point, it's 1.5 millimeters. And I think it is really concerning. Back to the 12 lead now, and take a look at it again. And do you see a pattern of the ST elevations? Well, there are septal elevations for sure. There are anterior elevations, lateral elevations. AVR is up too, along with reciprocal changes in the inferior leads, and that makes sense. But this is a 39-year-old male. And if he had all these elevations as a result of an acute occlusion, he'd be really sick. He'd be crashing, he'd be shocking, and he isn't. So, the patient was treated with aspirin and nitroglycerin, and his ECG seemed to get better. And you can see the resolution of these ST segments. But because of his history and the fact that he had mild disease and his worrisome, pattern, he was taken to the cath lab where it was shown that he had no occlusions, and he was diagnosed with what's called Prinzmetal angina. Now, Prinzmetal angina, it's a very specific thing. It's spasming of the coronary arteries, and it's really important to understand that the focal proximal coronary arteries are seen as spasm only in about 50% of cases. So you don't necessarily see this classic finding in all cases. Here's the example. Here's the appearance of what the T waves look like. They're broad, they're tall, and they're peaked, not narrow and peaked like in hyperkalemia. They're broad, symmetric, and peaked, along with an elevation of the J point. A few points about this. If spasm persists, there's progressive ST elevation lasting for several minutes, and then it spontaneously kind of gets better. And if you treat it, it does get better. There's also, some people have talked about the predictors of impending ventricular fibrillation in the setting of Prinzmetal angina. And there are a few predictors. Duration of episodes is important, the degree of ST elevations on this 12-lead ECG, and the presence of ST segment alternans. That's something that is not common, but when you see it, you should be worried. And here's an example. This is not from this patient. It's downloaded off the web, but you can see how these ST segments here change in amplitude. All right, and as you can see, this is something that is seen in Prinzmetal angina. Not common, but when you see it, you've got to be super concerned. The most dangerous complication of Prinzmetal angina is ventricular fibrillation. So keep your eye out for this. It is not a benign thing. Arrhythmias are a true complication and can get the patient in a whole boat of trouble. So anyhow, that's it for this week, guys. Glad you could join me. Until next week, this is Sush. Take care.